Connect my audio. There we go. Good morning again. So it's actually afternoon now, but we're going to start again and try to get through 35 and 36, and hopefully you'll be able to access this. Did a test run. All seems to be in order, and I apologize for the Adobe mishap. Seems it's been a quarter of that. So let's talk about brain injuries a little bit. So we have covered stroke extensively in the classroom, and therefore you should have a good handle on that, and then that'll be, a big piece of your final exam questions as well. But today we're going to talk about brain injuries that 1.4 million people per year um, um, are involved in or suffer from a brain injury, and about 5.3 million people are estimated to be disabled from brain injuries. Now, there are a couple of different types of brain injuries. There's both primary and secondary types. The primary type is a direct injury to the brain, maybe from an object, a motor vehicle accident, fall where the head hits something on the way down, or even a fall from a ladder or from a high-rise building. Assaults, firearms, sports and recreations, all of those things are causes of brain injuries in general. And then secondary injuries are, are a big piece of why we need to be so astute and ready to have great assessment skills surrounding the neurological system, because secondary injuries occur as a result of the primary injury. Things like hypoxia and cerebral edema and hypotension, things that decrease perfusion. And even the extreme hypertension can be the cause of a secondary brain injury as well. And so when we talk about primary injuries, we talk about this external force to the head that alters our state of consciousness or drastically decreases it. It does impair cognitive abilities. Okay, hopefully you heard all that. Partial or total functional disabilities for primary brain injuries. If that primary brain injury is open, that means there's a break in the skull, just like an open fracture. And this can be from something striking the skull again, or skull striking the ground. A hammer to the head is a good example of actually a depressed skull fracture where the skull is actually pushed inward. Basilar skull fractures are the ones that we need to be cautious and monitoring the patient for CSF leaks, either through their nose or their ears. Remember, we talked about the yellow halo on a dressing, white dressing, or else glucose is how we can test to see if something actually is cerebrospinal fluid that's leaking. Any clear drainage always needs to be suspicious and ruled out when you're dealing with patients with head injuries. Closed fractures are just that. There's no fracture in the skull. It's an uncontrolled energy transfer to brain tissue. And then we're looking at Coop and contra-Coop type injuries. And if you look on page 970, figure 35-6 of your book, it kind of talks about Coop. And a Coop injury is where you have an injury right at the initial impact. So if you hit your forehead on the steering wheel, then it would be right in the frontal lobe area. The contra-Coop injury is one that's from a secondary impact. So as your brain bounces forward and hits the front of the skull, it then can ricochet or whiplash back, so to speak, and hit the posterior aspect of the skull. So the contra-Coop would mean that the injury is actually to a remote site from the point of impact. And, then these patients can deteriorate very quickly from the risk of increased intracranial pressure, which is a secondary injury that we talked about earlier. These secondary injuries can come hours to days. And so it's very important that you have good assessment skills surrounding these patients and that you know where they live neurologically at all times. When we have an increased intracranial pressure, this puts pressure on the vasculature and decreases circulation, which alters perfusion and leads to, perfusion being altered. Same thing with hypotension. If you don't have the circulating blood volume, then you can't really perfuse the tissues. And then on top of that, we have the inflammatory process that helps us a lot with edema and increasing intracranial pressure too. We talked a little, we've been touching on the patho a little bit throughout the introduction, but primarily the first thing that is a concern. Okay, so now that I got the leaf blower out of the background, my goodness, I'm sorry for that extra noise. We were back to the pathophys. We talked about the blood vessels and how their integrity is important. Neuronal axon disruption is another characteristic of the pathophys here, and cell body disruption. So not only are we losing neurons to damage, but extending that through perfusion issues leads us quickly to that secondary injury that we're trying very much to avoid. Increased intracranial pressure, we talked about that damaging tissue. We also talked about if it was an artery, that it would be a very sudden onset of signs and symptoms. And if we were talking about a venous bleed, then the actual onset of symptoms could take hours to weeks. The patho that surrounds the secondary injuries becomes a little more involved. It talks about autodestructive factors that contribute to additional injuries that lead up to secondary injuries. We're concerned about cellular anoxia and depletion of energy stores. And so we need energy to maintain normal intracellular calcium levels. So calcium has to be, if energy supplies are low, then calcium plays a big role in neurotransmission. And then you get this influx of calcium into the neurons that results in a cell-mediated or calcium-mediated cell death. So not a good thing for calcium. We talk about oxygen needing O2. We'll get into that a little more. And then glucose becomes very important too because we need a constant supply of glucose. We learned that in diabetes. And so the utilization of glucose and blood flow is altered through head trauma. And so the inflammatory processes and cerebral edema all lead to increased ICP, or increased intracranial pressure. And when you have an increased intracranial pressure, your compensatory mechanism is that you develop a higher blood pressure to help maintain the blood flow to the brain. And the problem is that this vicious cycle leads to further cell death and just doesn't really promote a good outcome for these patients. And then if you get too much intracerebral pressure, then we talked about pressure on the brainstem. It affects that third cranial nerve, the pupils. You have pupillary changes, and also pressuring the respiratory center. So you get changes in respiratory rate and rhythm, and maybe even respiratory arrest with herniation. So we call that herniation through the brainstem, and that's what we would like to avoid. And so the primary culprit of that is increased intracranial pressure. We need blood pressure to maintain our blood flow. We talked about that, but not too much. Temperature regulation is something that can be altered as well with increased intracranial pressure as well as fluid balance. So all of that is like on page 965, 966 of your book. All right, more about heads. We have mild, moderate, and severe head injuries. And And so when we talk about a mild head injury, we're talking about those concussions with a brief level of consciousness. The patient may suffer some memory loss either before, after, or with the event. Mental status changes, they could be confused, or you might even see changes in their neurological status. But typically these guys come out of this smelling like a rose, no disabilities, and they recover rather rapidly. Patients with concussions, you can't always see that on a CT scan, but clinically they can rule in for a concussion. And so just because diagnostics are negative doesn't mean that the patient can't be ruled in for a concussion. Now, in patients who suffer a moderate brain injury, they do lose consciousness anywhere from minutes to hours to weeks, and their symptoms can also last up to several months and with permanent disabilities. They usually can recover from these disabilities and adapt to them and become fairly functional and independent again. Severe head injuries, not so lucky. Prolonged level of loss of consciousness, severe neurological deficits, very limited in their recovery with permanent disabilities. And then table 35-5 in your book talks about the types of severe brain injuries. So there you have it, coma, vegetative state, and you can see in a vegetative state they can be awakened, but they are not really know what's going on around them. Their eyes open and they respond to pain. If it's persistent, it's greater than a month. There's a minimally responsive state, so they have some basic reflexes there, but really can't follow directions, but have an idea of their surroundings. And then there's that locked-in syndrome where the person is actually conscious and able to think, but unable to move any part of their body except for their eyes. And then once in a while you do hear of a case like that, and how terrifying that must be. And I always wonder, how do they really diagnose patients like that? So it's the kind of thing we ask them: if you can hear me, blink your eyes once. If you're in pain, blink your eyes twice, and eventually figure it out. So review that table. That's on page 966. Complications of brain injuries. So hydrocephalus, the first one that your book mentions, when there's too much CSF in the ventricles, of course that puts pressure on the brain and they have a deterioration in their neurological status. So what we need to do is remove some of that fluid. We can use a shunt where they'll shunt the blood into the peritoneum, so it can, or the CSF into the peritoneal cavity, so it can be eliminated that way. Infection is always an issue, especially with an open brain injury. So antibiotics, prophylactic antibiotics, even with any open fractures, guys, everybody gets the antibiotics home sooner than later because of the infection risk of that direct access in, so to speak. A stroke can be secondary injury, especially if they have an intracranial bleed associated with the head injury. Chronic headaches are an issue. Those patients should be treated with analgesics. Narcotics should be used very sparingly because of the alteration in neural status and the safety and fall risk it puts patients at. And then memory issues is also a potential complication of brain injury. So how do we assess these people? Well, it's pretty in-depth, and you need to be a little private investigator, and a lot of times patients are no help to you with these types of injuries, so you need to seek out the family members and interview them. What is their clinical presentation? So where is their brain injury? Where is the injury on their head? So the location and the extent is very important. These patients are unpredictable, and they can deteriorate very rapidly, so we need to be very meticulous with our assessments. Not only do we need to do in-depth assessments, but we need to do frequent assessments so we can detect even the most subtle changes. So box 35-3, where's that? Talks about Signs and symptoms, yes, there it is, 968. There's both physical, cognitive, and behavioral types of signs and symptoms. So make sure that you look over that box. I'm not going to read it to you, and so you know what types of behaviors or cognitive symptoms fall into those categories. What's really important when a patient accesses the healthcare system is to know what the mechanism of the injury is. So a good, thorough interview of pre-hospital personnel is important if you're in an emergency room situation, or even if you're just involved in something on an acute care floor. Did they have loss of consciousness? Are they confused? All of those things that we're talking about, rules them in for uh, mild, moderate, or severe head injuries. All those questions need to be asked. Also, signs and symptoms of bleeds, neural bleeds. 35-6 has all of that for you, the symptoms of those and the potential treatments. And those are important, and we talked about those areas in class when I was, what am I trying to say? When I was introducing the concept and explaining the concept to you, we talked about these areas of the brain, the subdural, the epidural areas, the subarachnoid, and so those are all areas that we can have hemorrhages or hematomas form, and so those are, and they're pretty common, so you're going to need to have a fair understanding of that. Of course, we're always going to be looking for ABCs first, right? Especially if they're unconscious, we want to make sure they have an airway. C-spine immobilization, please don't get sidetracked. Many of these folks have accompanying neck injuries, and you have to assume they have a neck injury if they're unconscious. Their neurological function, so we will mobilize them, backboard and stiff collar. A Glasgow coma scale is very important, that universal scale we use to determine someone's level of consciousness. A pupillary exam, so we want to, do they react to light? What size are the pupils in millimeters? And are they symmetrical? They are considered asymmetrical if there's greater than a millimeter of a difference between the left and the right. Additionally, you can call pupils dilated when they are greater than 4 millimeters, but typically you'll find pupils to be, in a normal pupillary size, to be about 3 to 4 millimeters. Temperature, check their temp. If they have damage to the hypothalamus or they have pressure, or even an infection brewing, they will be very warm. And then any other injuries. So don't forget, these patients come in, they're train wrecks. Sometimes their brains are visible, or maybe even maybe even a deformed extremity with a bone sticking out will sidetrack you from that head injury. So make sure that you're very meticulous about your assessments. It's never good to turn somebody home and over and find that gunshot wound entrance, and that happens fairly frequently. Diagnostics, well, we've been talking about those. The neuro exams, the neural scales. If we think a vessel's involved, we're going to do some angiography because we want to locate that bleed within that brain. CT scans will help us to know where blood is. And we may have to go down the angiography road to see, to locate the exact vessel. If there are non-bleed injuries, MRI gives us, of course, the best picture. PET scans shows us brain metabolism. And then just a battery of lab work just to prepare the patient. So the CBC, the CMP, toxicology. Remember, there is a high correlation between drugs and alcohol ingestion and head injuries. So certainly we need to know what's in these in their systems before we go treat them. We may type and cross them if they need a transfusion. If we're concerned about brain depth, they get the EEG, that electroencephalogram. And then ABGs if their respiratory status is of concern. Planning and implementation, well, prevention. We like to prevent head injuries through education of the general public, and those at risk as much as possible. The people that are at risk for the head injuries are the very young and the very old, and even adolescents are at high risk. Elderly people have sensory deficits, they have slower reflexes, and are just not as agile with life as younger people are. So legislation to further for safety products, devices, seatbelt laws, helmet laws, DUI laws have gotten more protective of the individual. Need to assess patients' home environment sometimes. Make sure there's no throw rugs, there's good lighting, maybe they need handrails. Encourage the elderly folks to keep their muscles and joints flexible through regular exercise. This will also serve their balance well. And then medications. So many are on so many meds with side effects that really increase their risk for falls. So all of that needs to be considered. And don't forget about domestic violence. Every person has to be screened for domestic violence, and legally it has to be reported. So as far as management is concerned with mild head injuries, most of those patients are home within 24 hours. They follow up in a few days. It is a myth that they can't go to sleep, and that's still a big myth that's out there. It's your job to educate them that they can go to sleep. You just somebody needs to wake them up every 2 to 3 hours to assess their level of consciousness. And the way they need to wake up is the way they would wake up if they were sleeping. If for some reason they're difficult to arouse, then they need to return to the emergency room. Other things that would send them back to the emergency room would be a severe headache, nausea, vomiting, visual changes, and paralysis. And it's not just one episode of vomiting either. It's the nausea and vomiting should be something where they can't keep anything down and they need to come back for fluids. Certainly, I talked earlier about a clinical concussion. Sometimes those patients will vomit once or twice as they're recovering. Shaking up your brain a little bit, it's not really happy. And so it's not uncommon to see an episode or two of vomiting. So make sure they know if they throw up once, they don't have to run back. That they should be, if it's a consistent thing, then that's when they need to seek the health care. All right, management of moderate to severe head injuries. We've talked a lot about this already. Pre-hospital, ADCs, can't get those ABGs out of my head. So ADCs, and then that continues in the emergency department as they come in intubated or maybe on high flow O2 100%, which is what they're all going to come in on anyway if they're not intubated. Then we need to be assessing their O2 saturation, putting them on a monitor. We really want their O2 sat to be at 100%. If it's less than 90%, it has been shown that these patients have a poor outcome. So it's important that we are oxygenating them so that they can adequately perfuse to eliminate neuronal cell death. If the patient has bradycardia or any dysrhythmias, that is going to affect perfusion, so those need to be reported as well. They need 2 IVs. They need normal saline because that is an isotonic solution, and so that will not serve to increase intracranial pressure. We want to keep ICP down. These patients, we want to give them fluids, we want to maintain their blood pressures, but on the same side, we walk a fine line because we want them to be on the dry side. We certainly don't want to fluid overload them and add to our intracranial pressure in that manner. We also want their mean arterial pressure to be greater than 90. So you're looking at a blood pressure that's high to have a mean greater than 90. The other factors or assessment things we can look at is their urine output. If they would have a sudden increase in that, that would signify increased intracranial pressure. And then there's the Cushing's response that your book talks about, which is a late sign of ICP. We don't want to see the Cushing's response. Bad, 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 where we are now bradycardic, our respiratory rate has dropped, and the patient's hypertension. So that could signal an impending herniation. Check their temperature. They may need cooling blankets or some antipyretics, such as Tylenol rectal, if they have a temp. For every 1 degree your temperature goes up, it increases your metabolic rate 7%, which burns more energy, which is going to increase your neuronal death because you'll need more perfusion and more caloric intake for that. Let's see. So figure 35-8 talks a little bit about increased intracranial pressure and just how we monitor patients in that setting. And so look over that and troubleshoot yourself and see if you know the signs and symptoms of increased intracranial pressure and if you know what nursing interventions surround that. But we're going to talk more about them here. But that is important to know. And when the pressure is too high, we like that pressure to be below 20. If not, we probably need to remove some CSF. One way we can help decrease intracranial pressure is through an osmotic diuretic, and mannitol is the drug of choice. Your book talks about, we used to hyperventilate these people in the past, but that is no longer valid according to evidence-based research. So we want to just give them some mannitol, keep their head bed elevated, drain their CSF if they get too high, keep that environmental stimuli to a minimum, low lighting, low noise, restricting visitors. Their necks should not be hyperextended. Their bodies should be kept in alignment, shouldn't be stretching the neck whatsoever. And so our goal, not our goal, but again, keeping that ICP below 20. Some other goals for the best outcome of these patients is with cerebral perfusion pressure. I think we chatted about this briefly with the concept introduction, but that's the difference between their ICP and their MAP, or their intracranial pressure, and their mean arterial pressure, right? Our goal for the best outcome, or the evidence-based research proves that if you can keep their SaO2 at 100%, keep their PaCO2 between 35 and 40 on ADG, their intracranial pressure reading should be less than 20, we covered that, and then their CPP, or their cerebral perfusion pressure, should be greater than 70. The normal cerebral perfusion pressure is 70 to 95, so we'd like them to be just greater than 70. Remember, these patients are immobile, they need lots of nursing interventions, okay? So DDT and PE, prophylaxis, SCDs, anticoagulants, skin, turning them every couple hours. Remember, their head of the bed is elevated, so if you think about which body areas have the most pressure on a mattress, you should be thinking about their coccyx and their sacrum are most at risk. And then pillows to support all their extremities. Pharmacologically speaking, we want to prophylactically treat them to prevent seizures, which they're at high risk for, so they'll receive Dilantin, both a loading dose and probably about the first 7 days, they will receive Dilantin until they're out of that acute zone of seizures from intracranial pressure and inflammation. Anti-anxieties, antipsychotics, potentially, but research shows that beta blockers, anticonvulsants, and antidepressants are more effective for agitation and aggression. If you see and ever take care of patients with head injuries, they go through a period where they are very agitated, restless, and sometimes just you have to keep them down just to keep them safe. And so it's very challenging for the nurse to manage these patients. They can be hostile, they can be belligerent, they can swing at you. They're aware of their surroundings, but they really don't comprehend and have the understanding of what's going on as their brain is healing. The other thing I tell people too with head injuries is that it's not like the rest of your body. Sometimes it'll take 6 to 8 weeks for your brain to settle down and recover, whereas a wound on your hand or a sore will heal in just a week's time. Surgery is indicated for some patients if they have a hematoma, which is a large clot. We might do a craniotomy. If they have a lot of pressure in their head, potentially they could put burr holes where they just um, use almost a power screwdriver to um, um, put holes in their cranium so that they have room for swelling. The only problem with this, obviously, is going to be a high risk of infection. So they're not, it's not really the front line. And a decompression craniectomy is another thing, where they actually remove a piece of the skull to make room for the swelling. So family and patient education, very important. There is a wide variety of emotions that fluctuate. Uh, this is a very scary time. The ICU is a very scary place. You need to support, encourage, and inform and explain everything. Constantly be talking to your family. They'll love you for that. They don't want you coming in and doing things and not saying anything. I don't know how you guys feel, but when I go to the doctor and they take my blood pressure, I expect them to tell me, or I'm asking. I think it's really rude to take somebody's blood pressure and not always inform them so that they know about where their blood pressure runs. So it's important that people know what's going on with them or their loved ones, and try to pick one or two family members to be the primary, that may be the primary caregivers. Sometimes you get overwhelmed with people wanting information, and with our HIPAA laws, it's not as bad as it used to be. But I can remember times when I've had to tell people, I need one person to be the spokesperson because I can't keep yielding all these calls and then care for your loved one. And that's always a good thing if you do need to care for their loved ones. You can say to them, I'm sorry, this call is taking my time away from caring for your brother or your sister. Could you please talk to your mother about this, or vice versa? And sometimes that's a better way to handle that, and to get them off their back, and to get them to stop bugging you, multiple family members in that sense. And so that is it for brain injuries. Let's move on to brain tumors. Um, so about 40,000 people annually will develop a new brain tumor. 25% of all cancer patients will develop brain metastasis. There's a diagnosis no one ever wants to hear. 25, we said that. Um, Lung and breast are the most common sites, primary sites that will be metastatic to the brain. And the 5th, 6th, and 7th decades of life tend to be when brain cancer occurs in one way or another. Men are at greater risk than women. We don't really know what causes it. In some cases, there is a genetic link. We talk about tumors. All cancer, you can be benign or malignant. Benign brain cancers, not really good. They're not cancerous. They can be in one location and be slow growing, but the problem is they still grow and they still exert pressure on brain tissue, which causes neural compromise, so they usually have to be removed. Malignant obviously is cancerous. They are faster growing. They spread. They're usually fed by blood vessels into the tumor itself, will grow into the tumors. They're graded from 1 to 4, 1 being the least cancerous and 4 being the most. And that grading determines the type of treatment and how quick we need to treat a patient. Surgery usually is the front line of treatment. And there's always chemo, radiation, and surgery. Pretty much it for most cancers. There are a few other alternative things. If that cancer is primary in origin, it originated in the brain. If it's secondary, it came from another location. We said again, lung and breast would be the most common. The other thing is if it happened at birth, obviously it was a congenital issue, and if it happens after birth, it's called a neoplasm. So the most common gliomas are the most common. In kids, it's astrocytomas, and in adults, it's glioblastomas. And we usually treat these types of tumors with surgery. The CNS lymphomas, if you should have a lymphoma in your CNS, that's diagnosed through a lumbar puncture. You need a CSF sample to look for abnormalities there. And then meningiomas are from the coverings of the brains, right? The meninges we talked about. Those occur 25% of brain tumors, those greater than 40 typically. They tend to be slow growing, non-malignant, but the problem with those is that they regrow. And you will occasionally hear people having these and having, you know, had surgery and then having to go back to have surgery again later. And then there's adenomas, which are pituitary tumors. 10% are actually adenomas or involve the pituitary gland. Remember, we secrete all these hormones from our pituitary. So we have two types of those tumors, and it's just that simple. They're either secreting or non-secreting. We'd like to have non-secreting so that those hormones stay in check, but if they are secreting, then they release them, and you have the side effects of the functions of those hormones, so like impotence and amenorrhea and abnormal body growth, hypertension, hyperthyroid, hyperthyroid typically. And so if you need to go back and review the anatomy and physiology of the pituitary, then you would probably be able to, if you have an understanding of that, then you would know what symptoms may present in a patient who has a pituitary tumor that is secreting in nature. And then an acoustic neuroma, the cranial nerve 8 is the acoustic nerve. We also call acoustic neuromas, or Burke calls them schwannomas. And if you think acoustic hearing, then you can think that they affect balance and hearing, because right, the ears have those two functions for us, not only hearing, but they affect balance too. Signs and symptoms of brain tumor early are going to be vague. 50% of all people have a headache, and that tends to be worse in the AM. If it's an occipital tumor, they may have visual changes. If it's a frontal tumor, it may involve their personality and some memory deficits. If the tumor has already begun to increase intracranial pressure, then your symptoms will be more generalized. And we've gone over those increased intracranial pressure signs and symptoms more than once now. Coughing, sneezing, seizures are problematic, especially if there's no previous head injury. It always worries me when I get a person that's beyond probably 40 or 50 with no history of seizures comes in with a seizure. My first thought is brain tumor. And those are never good thoughts to have. Nausea and vomiting from the headache or increased intracranial pressure. Visual changes, ringing, buzzing in the ears, balance, dizziness, hemiplegia, paresis, poor memory, poor concentration, communication challenges. Sometimes patients can present even with some facial droop and then be diagnosed with a tumor. So very high anxiety, need a lot of emotional support for those patients. Diagnosis, pretty easy. CTs, MRIs, X-rays. If it's a malignant tumor and a lot of vessels are innervating the tumor to feed it, then we might do angiography just to get a better look at the vasculature in that area. EEG for seizures, but the two most important components of diagnosis are to determine the origin of the tumor and its potential growth rate. So size and location. Treatment actually depends on cell type, and how do we get that cell type, and how do we get cell types of all cancers is we biopsy them. And for your brain, there's about 3 different ways your book presents. There's the needle aspiration, or simple stick a needle in and aspirate, obtain some aspirate of that tumor and send it off to pathology. There's stereotactic, which is needle aspiration with computer guiding, and then there's open. Go in, remove the tumor, send it off to pathology. Also, while they're in there, they can take just a frozen section and send it for and check the pathology on it right there. It takes about 15 to 20 minutes, and then if the surgeon needs to remove more brain tissue, if the margins are positive and more needs to be removed, then he's right in there, and it just saves some heartache for the patient later, and maybe improves the outcome, we hope. So planning and implementation, we talked about the surgical, radiation, or chemotherapeutic approach. The type and grade of that tumor will determine the course, the patient's general health, their past medical history also play an important role in determining their treatment. Some patients just are not surgical candidates. You've all probably seen this in one shape or form already in practice. But we need to seek an oncologist that has experience with whatever particular tumor that this patient has. So provide that appropriate referral, and hopefully your patient will be open to all treatment options. In the acute phase, patients are at risk for increased intracranial pressure, seizures, and post-op complications. Remember, again, they're going to be immobile. You have to have all of those special little nursing interventions in place. So you're going to want to know what seizure precautions are as well, along with DVT, PE prophylaxis, spin, ways to prevent pneumonia that we've talked about quite a bit. Chemo and radiation have lots of side effects, so it'll be important to manage those. One of the major side effects of both of those approaches is fatigue, which could be very heavy in these patients, but you need to make sure that you rule out other clinical causes of fatigue, like anemia. Procrit is a medication we can give to try to help patients boost up their red blood cell production. Antiemetics as well, Zofran, Tiogan, Synergan. All antiemetics can be given either before, during, or after treatments. Chemo's gotten so much nicer than it used to be. It used to just be dreaded and really torturing to patients. But luckily, with our pharmacological advances, the patients can tolerate the whole chemotherapeutic regimen better. Those on chemo, I've talked about this, they can become neutropenic 7 days out, so know those neutropenic precautions, and those people should not be around sick people. If they develop mouth and throat sores from either chemo yeast infections or Candida albicans, you can do antifungals for the patients. Nutritionally speaking, they need high caloric food in small quantities that are visually appealing because appetite becomes a challenge. If their memory is impaired, make sure that you put in place all the things that can assist that issue. And these are all nursing things. So orientation clues, clocks, calendars, lists, keep them on a scheduled routine. Short and simple teaching. So you really need to know where your patients live, cognitively, functionally, behaviorally. All of those things are important. Make sure that if they have issues with problem solving and decision making, that your approach is practical and applicable to everyday living. Advanced directives should become one of the major topics for these patients. They usually have time to get their affairs in order, whereas when they have stroke, not so much. Sometimes they can be aggressive, angry, have outbursts, and for those patients, we need to have good communication skills, a soft but firm manner, be caring, redirect the patient if they become agitated and aggressive, eliminate any triggers or contributing factors. So if the brother comes in and he's the irritation, please remove the brother. They need to have a calm, quiet environment that is not overwhelming or overstimulating. So limiting TV and visitors and maybe their phones. There is some pharmacological agents such as mood stabilizers, antipsychotics, and antidepressants that these patients can receive. Pharmacologically speaking, for brain tumors, steroids, corticosteroids to reduce edema, right? We talked about this. Anticonvulsants for seizures, antidepressants we've been talking about, anticoagulants for DVT, PE prophylaxis, chemotherapy. Again, those agents will depend on the type, the location, the overall health. There's a couple different broad categories of chemo agents too. Cytotoxic, which is cellular death, right? Things that fall under there are cisplatin and methotrexate. And then cytostatic, which stops cell reproduction. Interferon is an example of a cytostatic chemotherapeutic agent. The problem, we have those blood-brain barrier, which is a very protective, great thing to have until you need chemotherapy. And then we have difficulty getting our agents across it. So mannitol is that osmotic diuretic that will help us to get our medications across that barrier. I said earlier, surgery is usually the first line of treatment. Unless it's a metastatic tumor, then we will focus on the primary site. It could be palliative in nature. If you have a benign tumor, definitely it's going to be palliative and maybe even curative. You're going to have to go out and take it out, or it's going to compress on tissue again and have neurocompromise. So we can do a craniotomy, a craniectomy. We can do microsurgery. We do stereotactic surgery, where we have three-dimensional computer images. They do brain mapping now. And shunts, we talk about to a tube that's routed to the abdomen so that CSF can empty into the peritoneum. Surgical complications, kind of the same, a lot of the same things we have with all surgeries, with a few specific brain entities, like for the brain, hydrocephalus, increased intracranial pressure, seizures. When we talk about infection up there, meningitis becomes big on the list. DVT and PE actually are the most common complications that we see after a craniectomy or craniotomy. So pre-op education to both patients and family members about the surgical process and what to expect post-op, not only for tubes and drains and the environment if they're in the ICU, but what to expect nurses to be doing regularly. Post-op, nurses will be doing vital signs, neural checks, the Glasgow Coma Scale. They'll be assessing the wound, the dressing site. And so all of those things need to be portrayed to the family members. Maybe what kind of medications, how their pain will be handled, et cetera, et cetera. Radiation-wise, if the patient receives radiation, then that's a game of energy to kill tumor cells. Radiation usually decreases size, slows the growth. About a 6-week treatment is indicated. The problem is healthy cells are killed too. Okay, so back to radiation. Need to make sure that the patient is... Okay, so make sure your patient's not claustrophobic, they don't have allergies to dyes, their knowledge level, comfort with the procedures, because radiation can be stereotactic, where we can give a precise dose to a specific location, can be computer imaged, brain mapped, gamma knife radiation, and so there's different things. Radiation also is stereotactic radiation is indicated for smaller tumors or those that are for surgical candidates. So small tumor would be 30 to 35 millimeters. And side effects that you may see are headache, nausea, vomiting, and decreased hearing from that radiation procedure. So review that in your book. All right, that wraps up chapter 35. I'm going to move on to 36, and we're just going to keep this rolling. So I can roll on to something new, like building a final exam or grading papers. So probably make everybody happy. Chapter 36, spinal cord injury. This is a huge area, and there will be a significant portion of your final exam will involve spinal cord injuries. We're also going to cover Guillain-Barré, Bell's palsy, some cervical traction here, neurogenic shock. Rehab is big, very big in spinal cord injury. Peripheral nerve dysfunction, a lot of information. Trigeminal neuralgia, carpal tunnel. And so I'm going to blow through this. I have read all of it and have some highlights, but that doesn't mean remember the nursing focus when you're lifespan. So 1,000 spinal cord injuries each year. Average age 40.2 years. Life expectancy goes down with a spinal cord injury, the average life expectancy. And things that take out these patients when they're disabled or they suffer paralysis or their post-spinal cord injury is a pneumonia, a pulmonary embolus, or even sepsis. So most of these, well, over half, barely, are caused by motor vehicle accidents, but other things like sports, violence, falls, and in the elderly, even osteoporosis could be a cause of a spinal cord injury. So our primary prevention is safety first. And so drugs and alcohol, protective equipment, airbags, helmets, all those things we talked about for traumatic brain injury. And so when we talk about pathophys that surrounds this, then we need to be looking at the normal structure and function of your spinal cord. And so damage to the cord causes loss of transmission of impulses beyond the injury. You can have motor and sensory function loss. When you have a gray matter injury or an injury to the gray matter of the cord itself, then sensory and motor functioning. Let's see if I'm going to say this right. Gray matter. Sensory functioning. Arises from the dorsal horn, so and from half of the gray matter. So sensory function becomes altered. And then you have the sympathetic nervous system that comes into play. And so that stimulates the release of epinephrine for the fight or flight response, but it causes vasoconstriction, increases the heart rate, and results in tachycardia. So then ventilation and perfusion are supported by the sympathetic nervous system, and so digestion and elimination are also affected. So sympathetic nervous system responses originate in the gray matter, and so those things become altered when you have a damage to the area, and this is very dangerous physiologically speaking for the patient. White matter. Cortical spinal tracts are there, so that involves your motor activity. The spinal thalamic tract is your pain and temperature sensation. The posterior column is responsible for positioning, vibration, and touch from the periphery. And then the parasympathetic system is affected when you have a white matter injury. And so then pay attention to your book for what the sympathetic and the parasympathetic effects can be on the patient. Upper motor neurons and lower motor neurons. So if you understand what consequences come from these, you should be good. So the upper motor neurons result in spasticity. And you'll lose reflex activity below the level of injury. So an upper motor neuron can result in spastic paralysis of the patient. When you're talking lower motor neurons, then that results in a flaccid paralysis. So upper is spastic and lower is flaccid. Signs and symptoms or clinical manifestations that involve the patient. First, a very thorough H&P. Okay, so very thorough history and physical, all that stuff I said for primary brain injury. You have to know the mechanism. What happened? Did the person fall off a ladder and land on their head? Did they fall off a ladder and land on their feet? There's injuries that can be predicted by knowing mechanism. Do they have a fracture, a dislocation? Is that cord compressed? Has it been transected? Is it do they have a deformity in the area that would be putting pressure on the cord? Um, have they lost their reflexes? Did they lose level of consciousness? And what are their reflexes? Do they have urinary or fecal retention, which can happen immediately post-injury? And we always do a rectal exam because if they have muscle spasticity, then they'll have no rectal tone and there'll be no resistance there. And you know, we all need that sphincter control and those muscles to be intact to have healthy, to be able to even hold in our stools. So they may even be incontinent right away. Spasticity and plasticity both vary with return of the reflexes. When we're talking a quad, we were talking a transection at the cervical cord, and we're talking paraplegic, we are talking thoracic and lumbar injuries to the spinal cord. Other degrees of injury can be a weakness or loss of pain, tingling sensation, urinary issues. And so it's really important to get a thorough history and assess your patient's motor and sensory function, reflexes, and just overall movement. So level of injury is very important. We can do this through x-rays and CTs, but certain levels, once you learn them, you should be able to predict how your patient may present. So if they are higher than a C3, they will lose their respiratory function and require mechanical ventilation, actually C3 and above. So above C4 requires mechanical ventilation. C6 seems to be the most common site because that's where the neck is the most mobile. Thoracic and lumbar injuries can still yield movement of the arms and the hands, but all of these injuries affect bowel and bladder function issues. T1 through T12 interrupt intercostal muscles and decrease their ability to cough and effectively clear their secretion. So again, a very stringent respiratory assessment of these patients is indicated. Cervical types of fractures that the patients may have. Cervical area, your neck area, is the most vulnerable. We can have flexion, hyperextension, or compression fractures. And so when you fall off a ladder, when you land flat on your head, or you dive in a swimming pool and hit your head, or jump off a ladder and land on your feet, those are types of things that result in compression fractures. Hyperflexion, most MVAs result in hyperflexion, which happens C5, C6 area. We see that in head-on MVAs. When we're talking hyperextension, we're looking at falls, strikes on the face and the chin, or maybe a rear end collision. And I could tell you a great hyperextension story, but just don't have the time. So in the essence of time, I'm going to skip it. But complete transection of the spinal cord is very common. And then I talked about compression already. Direct falls on the head, the feet, diving accidents, even on direct fall on the sacrum can result in a compression fracture. So there are types of incomplete spinal cord injuries, and your book refers to spinal cord injuries as SCIs, where some of the spinal tracts can be intact, and then motor and sensory function varies according to the level and the type. There are 4 syndromes associated with this, and 36-1 talks about the 4 syndromes, so make sure that you review those. They are the central cord, where you have a hyperextension, hyperflexion injury, which results in weakness in the upper extremities greater than the lower, and so on and so forth. The anterior cord, again, motor paralysis below that site of injury, decreased pain and temperature sensation, The thing about anterior cord is that touch vibration will be intact, position will be intact, and um, motor motor sensation will not be affected. Brown sequard is there. That's penetrating injury, which is a partial transection or hemisection. And so there are some functional deficits listed for that, and so is the posterior cord, which is a cervical hyperextension. And so a big thing there is losing your positional sense. Your book talks about the ASIA scale, which is an impairment scale for spinal cord injuries, the American Spinal Injury Association. The better the score, the better the outcome. So a grade A of that scale has the worst prognosis. Grade B has a mixed prognosis, but it assists us in understanding the functional abilities of patients with spinal cord injuries and potential improvement. So it's a predictor type of scale as well. 995 talks about primary and secondary spinal cord injuries. So make sure that you're reviewing that. Ischemia and hypoxia, of course, worsen these injuries, and as in brain injuries, secondary injuries that result from the low blood pressure, from the hypoxia, from the ischemia, from perfusion issues are something we need to prevent as well. There are also some non-traumatic spinal cord injuries, ankylosing spondylitis, rheumatoid arthritis, spinal tumors. All of these things can narrow the vertebral column and lead to spinal cord injury. So we diagnose this X-ray and CT. How we diagnose these. The nurse must be present during these examinations in a patient that's highly suspicious for spinal cord injury, so that we can prevent further injury and help maintain alignment. If we need to see C7, then we would pull the shoulders down to visualize that. An MRI will look at soft tissue or nerve damage as well. So what do? Always, always, always ABCs, and always consider a spinal injury. And when we consider a spinal injury, we immobilize the patient. They have to be positioned and immobilized. And research is, still pending on whether we immobilize them in the position that we find them, or whether we actually realign them and then immobilize them before we transport them to the hospital. So we will immobilize them. Respiratory becomes a huge area of concern, obviously, because their intercostals could be affected, their diaphragm, or they can just knock out part of their respiratory center. So pharmacological, emotional support, manage the team. This takes a huge team of individuals. The nurses plays a key role in managing the team, preventing complications, providing education to the patient, and then rehab, ongoing assessment and evaluation. And so I want to go in a little bit deeper into immobilization of the head and neck. It is standard of care at the scene, standard of practice to immobilize patients. If they have a helmet on, the helmet should be left in place because it provides nice protection. We said we're not sure, is it a neutral position or is it the position the patient's found in? That still remains questionable. But if they are in the emergency room, the doctor can rule out a spinal cord injury if the patient denies neck pain, if when we palpate that neck, it's non-tender, if they've had no loss of consciousness that may alter their ability to answer these questions, no mental status changes, no paralysis, no sensory changes, so no neurological deficits that can be seen, and no injuries of distraction that could pull us away from a neck injury. So if any of the above criteria are not met, then the patient must be ruled out with a PA and lateral x-ray of their cervical spine before we can remove those immobilization devices. Make sure when we're looking at x-rays, we want to diagnose vertebral fractures. Spinous, the spinal processes could be out of alignment. We could have soft tissue swelling. Again, MRI would be good for that. With thoracic and lumbar areas, remember we talked about T1 through 12 innervating the intercostal muscles. So the weak effort, the cough, low tidal volume, and vital capacity. If they have a T7, they're going to need, they already will need help with managing their secretions. But the problem with suction, we want to prevent hypoxia and bradycardia, so we have to be very careful about suctioning these patients. To hyperventilate them, hyperoxygenate, those types of interventions that surround this. If they have a T12 and above, they're at risk for pneumonia, so they need a vigorous pulmonary toilet. They need O2 sats to remain greater than 95%, turn, cough, deep breathe. They're very, very important in these patients. In these types of injuries, back to thoracic and lumbar, pain, loss of motor and sensory function, immobilizing them is important. Usually these patients don't have traction, whereas cervical spine injuries, you may see some traction, either halo or skeletal. We're going to get to that in just a second. Their support varies. They may have to go to surgery and have rods placed for stabilization. They may be on special beds. When we talk cervical, we're talking about traction that supports alignment. And so we can do cervical tongs or halos. But both of these require screws that are drilled into the cranium, which really are minimally painful, but imagine the power drill coming at your head. And these patients are usually wide awake. The people with halos are the lucky ones you see walking around. They have the stable C-spine fracture that is going to heal without neurological deficit. So there's high anxiety, so support those people. Make sure that you understand halo vest precautions, and they should be able to get 2 fingers under the vest and the shoulder pads so that there's no skin care compression, because skin care becomes an issue. They should not be moved around by those bars. They should not be. They should not get their screwdriver out and go at them, because that is one way that they apply the traction, is by manipulating those screws. And if any, and always the sites for infection. Good pen care daily. The sites should be draining. They can ooze a little clear drainage, but if they start to develop signs and symptoms of infection whatsoever, start draining, start getting inflamed, you just probably want to culture that and send it off to the lab and notify their physician. The nice thing is the halo allows them to be more mobile, and they can participate in something else. Cervical tongs, not so much. They have to be in bed, on bed rest. The weights should be hanging freely. They have to be turned with assistance always. They should be in body alignment, and those types of things. For less serious injuries, we can either use hard or soft collars. They're greater for movement. And they also, soft collars are really good for whiplash, and you've probably seen several people in those in life already. At the scene, though, we always put hard collars on. So early assessment is tough due to spinal shock sometimes, which can happen immediately. If they are in spinal shock, they have absent deep tendon reflexes, and they'll have flaccid paralysis. So it's really hard to get a neural assessment on those patients. But motor assessment is extremely is important. You may see, you want to look for extremity movement, movement against resistance, flexion and extension. So pull my feet towards, grab a hold of their feet and say, pull me towards you, push you away, hand grips, those types, and just overall, how are they moving their extremities. So some realistic rehab goals really depend on understanding the motor, sensory, and reflex activity that the patient has. Pharmacologically speaking, The problem with these injuries is that the inflammatory response exerts more pressure on the cord, which increases damage. So methylprednisolone has been shown, when given within the first 8 hours, to decrease edema and increase the blood flow. So that is still standard of care for these patients. And that's methylprednisolone IV within the first 8 hours. Adverse effects, of course, we're talking IV prednisone and steroids, so we're looking at a glucose rate going up, wound healing to be delayed because of the immunosuppressive nature of steroids, and increased risk of infection because we are slightly immunosuppressing this individual. So you need to monitor the effectiveness through daily weights and frequent assessments. Surgically, they can stabilize the spine with rods, cervical fusions, thoracic traction, posterior approach. Laminectomy is the surgery that you'll see. Pre-op education, kind of the same as craniotomies, right? Pre-op, what to expect. Post-op, in all areas of care. Neural checks, vital signs, pain control, wound care. Remember that post-op laminectomy, we always want to be assessing that dressing for clear drainage. If there's a dressing saturated with clear drainage, we need to rule out CSF fluid. So again, the yellow halo or the glucose. The heart monitor they're going to be on, those types of things. So complications, spinal shock. We talked about that a little bit. The higher the level of injury, obviously, the more serious the complications are. Spinal shock can happen within the first week and last up to 6 weeks. Makes our neural status and loss of function very difficult to assess. Remember, they have flaccid paralysis and no deep tendon reflexes. They have complete loss of function. It damages both the sympathetic and parasympathetic nervous systems. If you're above T6, you'll lose sympathetic input, and your parasympathetic kicks in. So you will suffer bradycardia and vasodilation. So initially, hypertension as catecholamines are released, but then hypotension. And when that happens, there's pooling in the extremities. They'll lose temperature control. The resolution of spinal shock is when reflexes return. And when they do, they'll be hyperreflexic. And they will also have reflex emptying of the bladder. A good indicator for us is the Babinski reflex returns. That indicates that spinal shock is resolving. So that's where you scrape your finger up the bottom of their foot and their toes flare out. And then in men, the bulbul spongiosus reflex, if I'm saying that right, which is the penile reflex. So treatment, we want to give a fluid volume challenge, but you have to be very careful not to put them into CHF because it can be a quick turnaround of fluids. For that venous pooling or pooling in extremities of bloods, make sure they have STDs on in some way to prevent DVTs because they're very much at high risk. And then your book talks a little bit more about neurogenic shock, which is typically T6, above T6. It's part of spinal shock. Excuse me. It presents with low blood pressure, bradycardia, and low temperature. You lose your heart rate response to hypovolemia. So you need a very astute assessment of fluid volume with neurogenic shock. Autonomic dysreflexia is another very common complication of spinal cord injuries. It can be very life-threatening. It is a massive discharge of your autonomic responses. The trigger for this complication is a noxious stimuli below the level of injury. So box 36-1 gives you noxious stimuli that can trigger this. Look at this: distended bladder, constipation, pain, sexual activities, pregnancy, even a tampon can be a noxious stimuli, a urinary tract infection, tight clothing, ingrown toenails, irritated skin, things like that can all be noxious stimuli below the level of injury. And how's your patient going to present? Well, first off, they're going to have this very high blood pressure to the tune of 200 over 100, which can be life-threatening and put them at risk for stroke. On top of that, they'd be bradycardic. They're going to have a headache as a consequence of that blood pressure, and they're going to be very flushed. So the priority of care for nursing or medical care is IDing and treating the underlying condition, the noxious stimuli. So if the patient has a Foley, is the Foley draining? There's no kink in the tubing so that the bladders become distended. Are they constipated? Um, do they have anything foreign going on below that level of injury? An infection, do they have a UTI? You have to rule out all that stuff. So you have to ID and treat this quickly so that we can reverse their symptoms and decrease their risk for stroke. So 1004 talks about nursing strategy that surrounds it, so make sure that you read that nursing strategy. Caregivers need to be educated about this. They need to give meticulous care to these patients. Some vasodilators may be indicated for blood pressure, which would be nifedipine and nitrates. Also, phenyloxybenzamine will block catecholamine release. So those are some drugs that can help us with some of those nasty, life-threatening side effects. Teaching, they should be changing their position every couple hours. They need bowel and bladder regimens. They need to be educated on this so they know when to call 911 at home. So make sure you know autonomic dysreflexia. I promise you'll have a question on that, at least one. Okay, rehab. This is really pretty in-depth. So understand from 1004 to 1008, there are several sections. I recommend you make a bulleted list of the nursing interventions that surround all of these areas. Okay, so those areas are bowel and bladder, circulation, pulmonary, mobility, sensory motor, psychosocial, spiritual, sexuality, and coping. There's collaborative management in here, and nurse, you are the collaborative manager. So nursing care, medical care, all impacts the outcome. It needs to be holistic. Outcomes of care are shown in table 36-3. There are cultural considerations in your book, so understand that. But 36-3 gives you an idea of some of the outcomes for care. Sometimes I like these outcomes for care because they give you like the resolution of a lot of the interventions that you do. So if you remember outcomes, sometimes you'll remember the interventions. And so rehab's going to be an important piece of spinal cord injuries. Huge. Bigger than really stroke. Let's talk spinal cord tumors. We don't know what causes these. Like brain cancer, they can be benign or metastatic. They put pressure on the cord, so they can cause a spinal cord injury. Typically, they have a gradual onset, and signs and symptoms appear after significant growth of that tumor and compression. Metastatically speaking, prostate tends to go to the thoracic region. Ovarian tends to go to lumbar thoracic. If you think about their close proximity, the prostate is very close to that thoracic, and the ovarian's more lumbar sacral, or your ovaries, and that gives you an idea of the closest sites to which things might metastasize to. But signs and symptoms of these tumors depend on the location again. If they're metastatic, they grow rapidly, and typically pain is the first sign of those. But bowel and bladder dysfunction, decreased sensation, weakness of the lower extremities. If it's an upper motor, again, upper motor spasticity, lower motor weak and flaccid. We talk lower motor, we're talking Brown-Séquard syndrome as well. So these patients may need to have intermittent catheterization for urinary retention, interventions that surround constipation or difficult elimination. And so growth of the tumor can be predicted at the onset of signs and symptoms. So doing a thorough history of signs and symptoms, onset, and the course of the disease will help you a lot predict the course. Diagnosis, history physical, MRI, CT, PET scan, myelogram. If we have a spinal cord blockage, a myelogram would ID that. So all of those, and biopsy, right? We need the cell type. So plan and implementation, preparing those patients for that diagnosis. The plan of care needs to be very supportive for these patients. Pain is a huge factor in these types of tumors, so corticosteroids may be indicated, surgery may be indicated, post-op chemoradiation. And if we're talking chemotherapy, we might be talking intrathecal, where they actually have like an Ommaya reservoir that they put into the ventricle of the brain, and that is sterilely accessed to give intrathecal chemo. So they would give injection of chemos, right? Injection of chemo right into the central nervous system. My dad actually had that. It was a very nifty thing. Corticosteroids. If they take steroids to decrease inflammation, make sure they take antacids. They tend to have GI upset. And dexamethasone, actually Decadron, would be the drug of choice when we're talking about steroids. Surgically speaking, if they have epidural metastatic disease, then they're going to want radiation in high doses and usually no surgery there. But if it's rapidly progressing and they're having bowel bladder, motor, and sensory issues, then the surgery may become an emergency. Extradural tumors are less complicated and easier to manage, but post-op for all these patients would be neural assessments, vital signs, pain, and watching patients for complications. Always, always, always. You hear about spinal headaches, you always report a headache for these patients. If they're metastatic to the spine, radiation tends to be the treatment of choice. So read over that section. Peripheral nervous system dysfunction or neuropathies, you've all heard that term, especially when it comes to diabetic neuropathy, which we treat with Neurontin quite a bit. That's probably another drug that you would like to add to that final exam list. But you get an altered structure or function of the peripheral nerve, so it could be motor, sensory, or autonomic function. Causes can be disease, metabolic problems. They can be drug-induced. They can be connective tissue disorders. There's several causes. Infection, trauma, neoplasms we were talking about. And so these nerves can be mapped using the dermatomes, which map out the various areas of distribution. Signs and symptoms of peripheral neuropathies: tingling, numbness, paresthesias, dysesthesias, which is a burning sensation. So those are things to look at when you're looking at neuropathies. Let's talk a little about Guillain-Barré. Love this disorder just because it's so interesting, and the few cases I've seen have been very interesting, and I've seen some both personally and professionally. Something I never wish upon anyone. But neuropathy, motor and sensory, throughout the peripheral nervous system, you have a neuropathy. It usually follows an infected illness, flu-like illness, so it could be a virus. And so it's very important when you're collecting your history to ask the patient these questions. It can follow a vaccination, a stressful event, or even a surgery. And it's felt that this demyelinates the nerve, so the impulses cannot be transmitted. So you get ascending motor and sensory involvement and weakness, maybe peripheral paresthesias or tingling. Autonomic dysfunction, if it gets kicked in, then the patient will have blood pressure changes, be tachycardic, may have facial flushing, sweating, and even pulmonary dysfunction. It does say that there are a couple of different types, both descending and ascending, but Guillain-Barré is characteristically an ascending, the only neurological disorder where it actually starts in your toes and moves up versus in your head and moves down. So it's felt that this can be an immune response where the myelin sheath over your nerves are being attacked. in the peripheral nerves, to be specific, because we're in peripheral neuropathies, right? And then you get an inflammatory response that results in edema and compression of those nerves. So most of these patients have the ascending weakness, symmetrical, deep tendon reflexes are either weak or absent. 50% of these people, as that ascending weakness and paralysis ascends up your body, have respiratory involvement and will need respiratory support. So history is very, very important. Assess their exposure, their history of symptoms. Respiratory assessment in this disorder or syndrome at all stages and constantly. The autonomic issues become a priority for assessment. So vital signs, paresthesias, dysesthesias, paresis. When you look at the respiratory status, the rate, the depth, the quality, the SaO2, do they have cyanosis? Are they diaphoretic, dyspneic? Do they have a lot of anxiety? People that are air hungry are very anxious, so that needs to be assessed too. So an H&P and an analysis of their cerebrospinal fluid may show an increased protein level for diagnosis. Otherwise, you're going to rule out other diseases. So treatment is supportive, especially respiratory. We're going to be monitoring their ADGs and their pulmonary function test. You're going to find that respiratory-wise, if it's affected, they'll have a decreased vital capacity. They'll have a weak cough. They'll have an ineffective airway clearance of secretions, and increased weakness from diaphragm and intercostals being affected. And it depends at what level that this syndrome travels up your body and where it stops. Some people don't have respiratory involvement. Some people end up on a ventilator and they're totally in there, but they're event dependent. And so it's a very, very, very scary illness. But the thing is most people recover from these. Most have a complete recovery. And I think it's like 10% or something that may have some residuals. And I actually have a friend who had a son who has a residual from it. But he was young, like 10 years old when he developed this. No steroids in this case. They have not been shown to be effective for Guillain-Barré. Plasmapheresis is indicated if you can get it within 3 to 4 days of onset. The problem is these patients can start out with some numb and weakness of their lower extremities and blow it off for a long, long time before they go seek medical attention. Hypotension is a high priority of management so that we can ensure perfusion. We want to prevent and treat respiratory failure. For the autonomic component, they need a heart monitor. They may develop a paralytic ileus, so they may need bowel decompression or an NG tube. They may have urinary retention, so you'll need to manage maybe intermittent catheterization. So all of those things have associated treatments and nursing interventions that surround them. If they are respiratorily compromised and they're on a ventilator, you need to think about how you're going to communicate with them. Their skin integrity, they are immobile. Remember, these guys wake up. This can take several months to resolve and make them wake up. So they wake up and they've got bed sores and contractures. They're not going to be happy campers and they're going to be coming after you. So make sure that you are very meticulous with their skin care, that you prevent DVTs because they are immobile. They need range of motion. They need contracture prevention. And ADL support is always necessary for these patients at some stage of this illness. If they're going to develop a contracture, you see a wrist or a foot or something freezing in out of alignment or an abnormal position, please splint that extremity or do something to prevent that contracture from happening. All right, trigeminal neuralgia, I can never say that word. Women over men, midlife and later. It affects cranial nerve 5, which is the trigeminal. It can be disabling, and this is facial pain, disabling, intense facial pain that can be sharp, stabbing, or burning in nature. So they really have no motor or sensory losses. This comes and goes and can last days to years. As they progress with this over the years, the exacerbations usually become less intense. They can have pain that will originate on one side of their mouth and shoots towards the eye, the ear, or the nostril. That is a characteristic thing. But look what triggers this. A breeze can trigger it, an air draft, eating, movement, touch. And the problem is they avoid these things, so they seek care when they're emaciated and really disabled in their appearance. Because if eating does it, then they're not eating. They don't really know what causes it. Dental infection and trauma can be associated. Trauma to that cranial nerve can be associated with it. But our focus is pain. We diagnose it through a history and physical. Their head CT scan will be normal. The thing is you really need to rule out multiple sclerosis because this can accompany this. But if it is an MF issue, then they will be suffering bilateral pain instead of unilateral. So pharmacologically speaking, the number one drug that responds the quickest and that helps the patient the most is Tegretol. Tegretol is an anticonvulsant. It carbamazepine is its generic name. It does have side effects of liver toxicity and bone marrow depression, so we certainly need to be monitoring their lab values, their liver enzymes, their white blood cell count. Additionally, Tegretol has a level to be therapeutic, so be careful that if we're watching the levels. The second drug we might use is Dilantin. Is also indicated that the nurse needs to be supportive, needs to monitor. These patients become chronic pain patients, social isolation, loneliness. They may be malnourished, so any of those side effects or potential complications of this disorder have to be addressed. All right, Bell's palsy. Now we're going to move on. Trigeminal neuralgia was cranial nerve 5. Bell's palsy is cranial nerve 7. It's an inflammatory disorder, a reactivation of the herpes simplex, usually. It causes a facial neuropathy, so pain and paralysis. And there's actually a picture of a woman that has it in your book. She's on 10/18. And so you see, one side of her face is normal. She can smile, blink that eye, raise her eyebrow. The other side of the face is paralyzed. And so that eyelid droops open. A lot of times they can't close that eye, so it becomes dry. They may have face. When they drink fluid that may run out of that side of their mouth, they result weakness or complain of weakness in that area, but it's self-limiting to the face. It can last days or months. So most of these patients, again, recover completely. History and physical, doing cranial nerve function. You're going to get cranial nerve testing next quarter. Their distorted face is a classic sign, and I always say, smile for me. And they have nothing from the neck down. Like they can walk and move around and function just fine, except for the talking and the eating. They may have, garbled speech. They may be drooling just from the facial droop. Might do EMG studies on those muscles, CTs, MRIs, X-rays. We want to rule out tumors. And sometimes if patients are older, you'll rule out a stroke too, but usually you can walk in. This is really a non-emergent issue. These patients, they may be put on acyclovir, which is an antiviral, right, for the herpes aspect of it, and corticosteroids, prednisone for 4 to 5 days, and then we'll taper them off that so we can reduce the inflammation to cranial nerve 7. Acupuncture has been shown to be very helpful in Bell's palsy. Treatment of Bell's palsy should be within 5 days of onset. If their eyelids are involved, if they can't close their eye, they should patch it or manually close it. And eye drops, they're going to have dry eye on that side, so they need to be lubricated. Frequent soft meals with soft foods, emotional support, and reassurance for these patients. If they have residual effects, and I do know somebody that does, he had facial shingles, which resulted in Bell's palsy, and he still to this day, you can tell that he had this problem, then they can do some facial nerve repair, but surgery is rarely indicated. Your book talks a little bit about peripheral nerve injury on 1020, so you can read over that. Trauma or entrapment of the nerve The brachial plexus is a common nerve to have an injury, and you get, again, all these P's, the paresthesia, the paralysis, the paresis, and the pain. It's important to be doing circulatory checks on these patients distal to those injuries. So capillary refill, pulses, can you feel this? Can you move them? All of those things help you check sensation, circulation, and mobility of extremities. So CMS checks, we haven't really talked about that, but that's very important not only in the neurological world, but anything distal to injuries. Patients have a hip repair, you need to be checking that in a foot. Patient has a central line, maybe a PIC line in their arm, you should be assessing their hands for sensation, mobility, circulation, so that it's not altered in any way from anything that we do. So in peripheral nerve injuries, we need a history of that injury. And then we'll do CTs, MRIs, mostly MRIs are good for diagnosing this, EMGs and nerve conduction studies that'll tell us the type and the amount. Surgery is indicated just as soon after the injury as we possibly can, because delays can mean loss in nerve function. And that can mean loss of motor function. So we need to be very quick on diagnosing this and carrying out our treatment plan. Pain through analgesics. These patients have to have PT and rehab. They'll be immobilized, so they're going to have splint or cast. And so, again, any splints, any cast, circulation to distal of that, to the fingertips, the toes, whatever, always has to be assessed. The warmth, the color, the tingling. And the patients have to be educated on splint and cast care and keeping those things elevated, and skin breakdown that can be associated with those devices that we have on the patient. Carpal tunnel, a very real occupational kind of hazard. It is a neuropathy. The median nerve is compressed in the carpal tunnel. Women are more prone to this than men, but as occupation related is the greatest risk factor. So you get that repetitive movement for prolonged periods of time. So keyboards, construction workers, athletes with repetitive activities, digital flexion activity, and some of the signs and symptoms that can clue you into carpal tunnel are pain or burning and tingling, an aching that increases with activity and is also worse at night. It can radiate all the way up to your shoulder. You can have sensory. It follows the neural tract, so like the first 3 fingers of sensory deficit, and then motor deficits. So we diagnose this with an EMG and a physical assessment. Your book talks about 2 positive signs being the Tunnel sign and the Phelan sign that would rule you in for carpal tunnel. What do? Well, we're conservative first. We splint these extremities, we rest it, we limit its mobility, and see if we can reduce the inflammation on the median nerve. They can have NSAIDs, steroid injections if needed. They modify their activity, but what we want to do is teach prevention and help people manage. There is surgery is an option for patients that have severe cases, and it is very successful. And again, the normal pre-post-op care. These patients with carpal tunnel surgery are going to have some kind of splint, some type of cast post-op to immobilize that extremity until healing can manage. Okay, that wraps it up. So that's an overview. Make sure you're reading these chapters and again taking that nursing approach. And I hope this is helpful for you. And I'm sorry it's so long, but these chapters have a lot in them, and I feel like I even jumped over, specific sections like the rehab, and just letting you guys dig into that yourself. So good luck with your studies.